much as far as ICU type patients, but or even even an ambulance patient that's got all the stuff on the ambulance stretchers. Trying to get that through a round door with all the other stuff like pumps and everything was quite a challenge. So we were quite happy when we were able to have a rectangular door where we could just wheel the stretcher in. We have a ramp that goes there, so it's not a big drop. It's just a nice, easy entry. The chamber right now is configured to have 8 seated patients and 1 nurse inside. And all those chairs that are on that side, and there's 6 chairs on this side, can all be removed. They sit on a rail. They're clipped to a rail system, so they can all be clipped out. So if a stretcher that's right here, for example, we had to treat a stretcher patient, these seats would be clipped out, taken out of the chamber, and then a stretcher could fit right in there for treatment. I got it. Thanks, Dan. And then you can see that we have that little, that looks like a TV screen at the end. That's our ventilator. It's quite a small ventilator. Akin to, it's a fully functional ICU ventilator, but it looks same size, I think, as a transport ventilator. And it is a specialty item specific for hyperbaric use. It's one of the only ventilators that's designed for use inside a hyperbaric chamber. And I'll talk a little bit why there's a challenge with equipment in the chamber. We have 2 programs. So I mentioned we treat 8 patients and a nurse. We'll go inside with them. That's usually part of our elective program, which operates Monday to Friday, 8 to 4. And those patients are kind of 4 main types of patients that we treat for that. So you got people with diabetes, and with diabetes, long-term side effects can be that their perfusion to their extremities gets poor, and they can develop wounds. And so they'll come for treatment here. We also treat something called radiation necrosis, so patients who get radiation for cancer, about 10 to 20% of those patients will develop something called radiation necrosis. So the radiation actually affects the endothelial cells of the blood vessel, the smooth cells on the inside, and can cause some disturbance in the blood flow. And so they'll develop sores, their dental caries, their cavities, the bone of their mandible might actually start to necrose. And so they'll come for treatments, and there's usually a surgical option along with treatment. So they'll come for a number of treatments, have surgery, and then come back for more treatments. We also treat something called osteomyelitis, which is a bone infection. So that can happen from, you can have dental work, and the bacteria gets in there and just likes the anaerobic environment and grows like crazy and causes all kinds of problems. Or sometimes you can have a diabetic wound that's gone to the bone, and it's got an infection inside the bone. So they'll come for treatment here as well. And then one of the newer things that we've started treating is something called sudden sensory neurohearing loss. And so all that means is somebody's, for example, gone to bed with normal hearing, and they've woken up the next morning and one side is drastically reduced. And the thought is that for what we treat, it's a virus that's gotten into that area, vestibular area, and is causing enough swelling and impingement on the blood flow to the nerve that the nerve is being affected. And so they'll come for treatment. The treatment will do a couple of things. It will help to reduce the swelling in the area, and then bolster up the blood flow, the oxygen supply to the nerve to help maintain that nerve while the body deals with the virus. Our patients that are in the elective program come from anywhere from 20 to 60 treatments, 1 a day, Monday to Friday. So it's a long treatment course for our elective patients. Some of our patients come from as far as Chilliwack, driving every day. We do have a large catchment zone because we're the only public facility in BC. So we'll have patients coming from all over the province to have treatment here. There's no other hospital-based facility anywhere else in BC. We've also had patients come from up north, from the territories, as well as from provinces as far as Manitoba. We're also the only multi-place chamber, so there's a couple of different kinds of chambers. This one is called a multi-place chamber, and you probably can figure that out because we can treat more than 1 patient at a time. There's also something called monoplace chamber, which is what most people are familiar with when they think of a hyperbaric chamber. Certainly in a clinical setting. It's the type that's just a tube, like a clear plexiglass tube with the 2 end caps. And so we're the only hospital-based multi-place chamber west of Manitoba, and so, or Ontario even. So that's partly why we'll get patients from as far away as Manitoba. There are some monoplace chambers in Alberta, but if you have confinement anxiety or claustrophobia, monoplace chamber may not be the best environment for you because it is a little bit of a small space. And so this is a bit of a bigger space, and you're there with other people, and most people have no problem being inside. So any questions? So that's our elective program. We also have an emergency program which operates 24/7, and so that treats patients that have scuba divers that get decompression illness, which most people associate this type of facility with. We'll treat carbon monoxide poisoning here. We treat necrotizing fasciitis or flesh-eating disease. Something that's very similar to that called gas gangrene, which is the same idea, just a different bug. We'll treat gas embolism, so that can either be through a hospital procedure, so open heart surgery, for example, they can get bubbles going up into the brain, or it can be scuba diving, so if a diver in the water column comes up too quickly, one of the things that happens with a volume of a gas, as you change pressures and you decrease pressure, that volume of gas wants to get bigger, and if for some reason their airway is closed and the gas in their lungs is getting bigger and bigger, the volume is getting bigger and bigger, it'll actually rupture the lungs. A bubble can enter the vascular system and go up to the brain and essentially causes a stroke with a bubble. And so they'll come for treatment here as well for part of our emergency program. That's pretty much it. Those patients will come any time of the day. So we have an on-call system that involves a physician, 2 RNs, ideally an RT, and then 2 operators who are from the biomedical technology group within the hospital. And so for any patient, we can have up to the doctor, 2 RNs, and anything from 5 or 6 people here just to treat one patient. So it's fairly high resources that we require for the operation of the chamber. And then patients are here for anywhere from 1 to 5 treatments, depending on what we're treating them for, and the length of dive. So I didn't mention, with the elective treatments, we do 2 a day, 1 in the morning, 1 in the afternoon. And those treatments go to an equivalent depth pressure of 45 feet of seawater. So it's like being underwater. There's no water involved, but it's like being underwater at a pressure of 45 feet. And they stay there for 2 hours and 15 minutes. So they're kind of stuck in the chamber for 2 hours and 15 minutes. For some of our emergency dives, we'll go anywhere from 60 feet of seawater to 165 feet of seawater. And we can be in the chamber for anywhere from 2.5 hours up to 9 hours. So there's some pretty long treatments. Any questions? Feel free. All right. And then you can see, so because of the length of the treatments, we certainly for our elective patients, we want to try and make sure they come back for their whole treatment course, so they can watch movies. There's a TV screen on either side, so they can at least have something to entertain them while they're there for 2.25 hours. They can read books, because the hood systems look very much like these are the hood systems that people will breathe oxygen through. So the chamber itself is pressurized with air, and then the patients that are inside will breathe 100% oxygen once they're pressurized. And so they'll have a neck ring like this one that will go on their neck. It'll be cut to size, and then they have 2 hoses. One's a supply, one's an exhaust. And then once we're pressurized, this hood just clips over onto this ring, and then we switch to oxygen. They'll get 100% oxygen while they're under pressure. And so you might ask, well, why do we put them under pressure and give them 100% oxygen? So the reason we do that is when you pressurize gases and fluids, that gas you can dissolve more of a gas in a fluid with pressure. And so one way to look at it is a bottle of pop. So when you have a bottle of pop, you don't see very many bubbles in that solution unless you shake it. You might see some bubbles. And then as soon as you take the cap off, and you hear that very nice noise, and that's the pressure being released in the bottle. And so once that pressure is released, then you can see lots of bubbles coming out of solution. And so that gas has been kept dissolved in solution because of the pressure. And so with our patients, for a lot of our patients that have challenges with the blood flow to a different area, whether it's radiation, necrosis, or the wounds, the hyperbaric oxygen, the hyperbaric chamber, by pressurizing, allows us to dissolve more oxygen into the plasma part of the blood, so the liquid part of the blood. And so it has a larger diffusion diameter from the capillary beds than just relying on the red blood cell. And so that's why we give them 100% oxygen under pressure for most of our patients. There's also a mechanical aspect to it. And so as I mentioned with when we're talking about the gas embolism and the lungs and the volume of gas wanting to increase as we decrease pressure, so the opposite happens as we increase pressure. So as we increase pressure, bubbles, gases want to go back into solution and the bubbles will get smaller. And so for example, with a scuba diver who's got decompression illness, does anybody scuba dive? Does anybody scuba dive? Okay, so you'll know a little bit about what I'm talking about, or a lot about what I'm talking about. So when you're scuba diving and you're under pressure and you're breathing air, most people breathe air when they're scuba diving if they're recreational, where you're absorbing not only the nitrogen, not only the oxygen that's in the air, but the nitrogen. And so nitrogen is it's an inert gas. It doesn't do anything. It just sits in your tissues. Whereas the oxygen is a metabolic gas, so it gets used up. The nitrogen that's sitting there in solution is fine while it's in solution and dissolved in our tissues, in our blood. But as soon as we start decreasing the pressure, so going up in the water column, that gas that's dissolved wants to come out of solution. And so depending on how deep you've been and how long you've been there, you may have a lot of nitrogen, and a lot of nitrogen wanting to come out of solution too quickly. And if it comes out too quickly, you have bubbles that will form together and form bigger bubbles, and then that's when you have problems. So you can block blood vessels, you can have bubbles in joints, you can have bubbles impinging on nerves, bubbles in your brain. You can have anywhere a bubble can form. And that's why with scuba diving there's decompression stops. So most people have heard decompression stops. And you do that to allow your lungs, which are a very good filter for that nitrogen as it's coming out of solution, your lungs will off-gas that nitrogen. And as long as you can do it in a safe way, then you won't get decompression loss. But sometimes things happen. A lot of things can happen underwater. You lose your buoyancy, you go straight to the surface, you don't have an opportunity to stop or whatever. And you can have too much gas coming out of solution at once and it overloads your lungs, you don't have a good filter anymore, and that's when you get decompression loss. And so when you have that bubble there, one of the things that putting them under pressure does is hopefully if you get them here soon enough, it'll shrink that bubble to a smaller size so it can, if it's blocking blood flow, then you can get blood flow back. And it'll also help to dissolve the gas that was forming that bubble into solution. And any tissue that's had some hypoxia, so it's had a decreased blood flow, will get a real boost in oxygen. So there's a few things going on when we're treating a patient with decompression illness. And then, so we'll pressurize them and then we come up very slowly while they're on oxygen. Any questions?
So what's the pressure difference between the hood and the chamber? Does the pressure in the hood?
There's no pressure in the hood, yeah, per se. So there's a little bit of PEEP that you have to push against. We have a valve. So for example, when the pressure is chamber's pressurized, and we have two pipes going out of the chamber, so exhausting out of the chamber. Because there's a lot of pressure inside and not much pressure outside, you get a lot of push for air to go out. And so we have valves between the patient and the exiting of the chamber. And so those valves are a diaphragm, and there's a little bit of pressure that the patient has to push against when they're breathing out to open that diaphragm, and then gas can be exhausted out of the chamber through the hose. But other than that, there should be no pressure in the hood itself. Yeah, just it's a systemic kind of application. Yeah.
When you're reducing the pressure, so if they're on 100% oxygen and the nitrogen is the concern for sickness and stuff, then do you have to worry so much about normalizing back to?
So for the patients that have been on oxygen, so they're pretty much on oxygen the whole time they're under pressure. And so because they've been on oxygen, they haven't been dissolving more nitrogen. And usually they're going to be cleaner than they are when they went in, as far as the nitrogen, what we call nitrogen. So they can come out of the chamber, they can pretty much do whatever they want as far as fly, with elevation and anything like that. The tenders, the nurses who are inside, so myself, if I was inside the chamber, I can't, when I come out of the chamber, I have a higher nitrogen percentage in my body than I did before I went in. Even though I'm safe to come out of the chamber, my decompression that I do doesn't get rid of all the nitrogen that I've accumulated, but it's brought it to a level that I'm safe. At sea level, for sure. Now I have to be, as a as a diver, I have to be careful what kind of elevation I go to immediately after being in the chamber. So just like when you decrease pressure, so as you increase elevation, as you go up a mountain or in an airplane, you're decreasing your atmospheric pressure. And so as you do that, the gas that you might have in your tissues that's dissolved and staying there at sea level wants to come out of solution and form bubbles. And so that's why if you're a diver, there's recommendations that if you go on a dive trip, for example, you're not supposed to go flying till 12 or 20, depending on what your background is, where you did your training. We recommend 48 hours for our staff. So we can't go flying for 48 hours after we've been in the chamber. We can't go up a mountain for 24 hours or higher than 1,000 feet for 24 hours, just because we would be at risk of getting decompression illness. Whereas a patient, because they've been breathing oxygen the whole time, they don't have any of those concerns. They can basically fly right after the treatment. Do you have a
How
question?
frequently do you have emergency patients?
It is, we have no, there seems to be no kind of pattern. So we can go months without an emergency, or we can have a week where we have emergencies every evening or every day. And so it really depends on, sometimes you can correlate a little bit, for example, carbon monoxide poisoning. When the season changes, so like it's changing right now, and we're going into a bit of a colder season. As soon as people start using their furnaces, if they haven't been properly inspected or checked out, they may be faulty. They can get carbon monoxide poisoning from your gas furnace, for example. So you might see a slight increase in carbon monoxide poisoning. Some people might think, well, and so that's non-intentional or accidental exposure. Of course, there's the intentional exposure. Somebody's trying to kill themselves. So you might think there's more of a pattern around holidays, but we don't see any kind of real correlation to that. Generally, and then scuba divers, people might think, well, it's summertime because it's nice weather, you might get more scuba divers, but in fact, for scuba divers in this area of the world, it's better diving in the winter. So there's more divers in the water in the winter because clarity in the water. So we don't really see a pattern either for that. So it's really kind of, we don't have any idea when it's gonna happen or what's gonna happen. Yeah. And then it certainly depends on ICU, because for example, I mentioned we treat necrotizing fasciitis. We don't treat every case of necrotizing fasciitis that comes into the hospital, because I know the ICU sees much more than we ever see down here. And so part of the reason that is they're quite, the physicians that are dealing with that up in the ICU, so it'll be plastics and maybe infectious disease, they're quite happy with their approach of surgery and antibiotics. And for the most part, patients do quite well if they're treated in a timely fashion and have good ancillary stuff going on. Usually the patients that we end up seeing are the patients who might have a lot of comorbidities, so they might be diabetic as well or have a bunch of other things going on. So they're not responding as well to what they're doing upstairs, surgery or antibiotics. And so we tend to see those types of patients. So the patients that we do see tend to be, especially at least from the ICU, tend to be a bit on the sicker side. We do have a certain amount of stability that a patient has to be at before they can be in the chamber, because you can imagine if you're in there with a somewhat unstable patient, and it might not be a great environment to have an unstable patient. So we do have a certain kind of threshold for how unstable somebody can be before they go in. And so, for example, if we have a patient that's been in OR and they've been having a heart transplant or a valve repair, and they've had a gas embolism go up, sometimes we will see patients come quite quickly from the OR, but they still need to be at a certain stability level. So, and that means that they have to, their hemodynamics need to be pretty solid before we put them in the chamber, because we really don't have good resources inside to try and deal with that. So, for example, in an ICU setting, if somebody is going downhill, you have a whole pile of resources around you. You've got doctors, you've got residents, you've got other nurses, you've got RTs. In the chamber, we're quite limited. So in the chamber, you might have a maximum of 2 staff in there, an RN and an RT. And then on the outside, you will have a doctor and 2 operators and what's called a circulating nurse. And so it can be a little bit of a challenge to deal with unstable patients. So we try and make sure that they're not going to bottom out in the chamber. Yeah.
So does that mean all of the staff, like the RNs here, are critical care?
Mm-hmm. Yeah, so it is, for anybody that's a scuba diver, we probably might know this as well. It's a bit of a gray area. There's a lot of controversies about whether it's safe to dive or be under pressure when you're pregnant, because nobody really knows the effect and at what stage of a pregnancy there might be an effect, iatrogenic effect from being pressurized. And so, if you read some literature, it says, well, it doesn't have any effect till later on, but we tend to err on the side of caution here. So if somebody's even trying, they don't go in the chamber. Yeah.
Why are there some restrictions on what can go in?
So it's a good question. One of the things that we're really concerned about in the chamber is fire. And so you can imagine if we're in the chamber and there's a fire, we have a really hard time getting away from it. And so, and compounding that is when you're under pressure, things that don't normally easily combust outside can combust quite easily. And that's because when you're pressurized, even though, for example, we keep the chamber pretty close to 21% oxygen and 79 or 80% nitrogen, just like air, even when it's pressurized. But those percentages are just representative of the percentage, but there's more oxygen molecules actually in the chamber. And so things can more easily combust. And so we put a lot of restrictions on what are allowed in the chamber. So anything that has a petroleum base has a higher risk of combusting. So we don't allow any of that. So hair products like hairspray, gels, they sometimes have alcohols and stuff like that. Excuse me. Clothing, if you have dissimilar clothing, so if you have if anybody's worn like an acrylic sweater or a wool sweater, you know that when you take it off, you have a ton of static electricity. And that's because you usually have two dissimilar materials, and when they rub together, they generate static. And then when they pull apart, you get a static charge. And anybody that's worked in a hospital have experienced that multiple times. When every time you will go around the stretcher, you're going to get zapped. And so we only allow 100% cotton in the chamber because it's a very low static generating material. Now, we used to use a product called Durette, which was a kind of a space age type of material that was self-extinguishing, non-flammable, it did catch on fire, anti-static type material. It was a rather expensive material, so a scrub set like I'm wearing right now would be like $600. So luckily we chose to go to 100% cotton, which is more like $30, so it helped our budget quite a bit. So speaking of fire, we do have, if anybody wants, does anybody want to go in the chamber? Yeah? Okay. So I'll give you a couple, just put these over your shoes. If you're claustrophobic and you don't want to go in, that's totally fine. So just take two booties. These doors are very heavy, so try not to move them around too much. They swing very easily, so it doesn't take much to get them moving. And so, don't be shy. And so this door, you've probably seen the chamber on the other side. So normally this door is closed like this. And so then we have 6 patients on this side and 2 on this side, and the nurse sits here. And so you can see there's a TV on the other side so that people can have something to occupy themselves or they'll be crossword or whatever. And then you'll see this is the valve I was talking about that they have to push against. So there's a diaphragm here, there'll be a hose hooked up to here, and when they breathe out, it's about 2 psi that they have a valve that they have to push against. It's a spring, and it opens up and it lets the air go out their hood. And we actually have pipes that go all the way outside the building, so we don't have any accumulation of gas in the building itself that might be high in oxygen. The panels that you see there, those will allow us to switch gases quite easily. So the supply that's going to the patients is coming from those panels. So some of the panels have oxygen and air hooked up to them. So the white hose is oxygen, black hose is air. We also have panels that have a purplish kind of hose, and that's heliox. And so you might wonder, well, why do we have heliox? And so when you increase the partial pressure of oxygen that you're breathing, So when you're adding pressure and increasing the amount of oxygen that can be dissolved in the tissues, our body's not really designed to do that for extended periods of time. Or if it gets too high, it can cause real problems. And so when we're treating patients, they don't have the hood on the whole time they're under pressure, but they have a total of 90 minutes of oxygen for our elective group, and that's broken into 30-minute periods. And we do that because there's two types of what's called oxygen toxicity. I don't know if you guys have heard of that. So there's respiratory oxygen toxicity, and then there's CNS oxygen toxicity. So respiratory oxygen toxicity, we don't see it very much with our elective patients, but sometimes we'll see with the divers who are here for up to 9 hours. They're breathing oxygen for a long time under higher concentrations than they would normally outside the chamber. And so what happens is their lungs get irritated. So they might develop dry cough, they might get a little sore when they're breathing, and that goes away once they're finished with the treatment. The other type of oxygen toxicity is CNS oxygen toxicity. So the brain gets really irritated with high concentrations of oxygen and doesn't like it. And if you, some people are more sensitive than others. And so, for example, if you have a history of seizures, you might think, well, we can't treat you, but we do if they're stable on their medications or if they have a seizure for a long time. But they're at higher risk of having an oxygen toxicity event, which can be the end result of the toxicity. CNS oxygen toxicity is seizure. And so we have to be quite careful of how we're administering the oxygen. It is a drug, and the levels that we give it. And so if you go deeper than 66 feet, and you breathe 100% oxygen, you are most certainly going to have a seizure quite right away, as soon as you start getting that oxygen into your body. It's such a high concentration. And so, with our patient, and so we use something called Heliox and as treatment. So when we go to, especially when at 165 feet of sea level, we definitely can't use 100% oxygen. So for our treatment gases, we use 50-50 Heliox. So it's 50% helium, 50% oxygen. And we do give them air breaks, just like I mentioned every 30 minutes we give our elective patients air breaks. We will give them air breaks with 20 and 80 Heliox helium oxygen. And so that's just to kind of help prevent them from having oxygen toxicity. So we don't breathe it, so we don't sound too much like chimneys. When you pressure, an interesting thing that does happen is when you pressurize the chamber, and the way it pressurizes, you just add more and more and more molecules, air molecules from the chamber. And it changes the density of the gas that you breathe. And so your voice changes. So as we go deeper and deeper, our voice does get higher and higher. And so when we're at 165 feet of seawater, we do actually sound like chipmunks. It would be way worse if we had to breathe on helium. So just breathing air at 165, our voices are way up here, and it sounds quite funny. And we do have a thing that what happens in the chamber at that depth stays in the chamber. Because what also happens is something called nitrogen narcosis. And so as you go deeper and more pressure is applied, nitrogen that builds up in your body gets to a point where it can affect your brain. And it's very similar to drinking alcohol. And so when we're at 165 feet of seawater, it's like having 3 martinis. And so our nurses that are at 165 feet of seawater are essentially drunk. And that's why we have the saying, what happens in the chamber stays in the chamber. But we're looking after a very sick patient. Usually those patients that come to that depth are the gas embolism type patients who may be coming from CSSU, so they're usually quite sick. Lots of pumps, a lot of ventilated patients. And so we're really robots down here. When we're at 165, we're there for 35 minutes, and when we're there, we just are doing what the people outside tell us to do, basically, within reason. So if we need to make changes on pumps, they tell us exactly what to do. We make sure they can see the pump, we'll tell them back what we're doing, they'll watch us do it, make sure everything is being done correctly. Same with the ventilator, if we have to make adjustments on the ventilator, we'll do the same process. And so we're at that depth. It also gets very hot and humid, so it can get up to like 45 degrees in here. We're at 165 and 100% humid. And so you're tropical, you've got a very sick patient. And then as soon as we come up, as soon as we get past like shallower than 100 feet, all that sensation goes away. So we lose our buzz, and it gets cold and clammy. So we go from a nice, it's not really a nice environment because I don't like hot and humid, but to being cold and clammy, and we're back to normal life. And then we're in the chamber for the remainder of like up to 9 hours with those patients.
Is there anything for like the staff in here if they start feeling too much effects like that? In terms of, you know, like maybe they have something like oxygen.
So we don't have we do oxygen decompression. So at the end of all of our treatments, we have decompression for our staff because the types of dives that we do all require decompression, and some of them longer than the others depending on how deep we are and how long we've been there for. We typically don't need any supplemental oxygen during the treatment itself. Yeah, but everybody does respond a bit differently to the nitrogen narcosis. So every nurse has a bit of a different quirk. Some people just giggle nonstop. Some people just get, one of our nurses just gets tingly feet. That's it. One of our doctors who comes in here likes to lift up his shirt and stuff like that. So it's just, so you never know what's going to happen when you're in that situation. So it can be quite entertaining for the people outside. So it's a very unique work environment. There's not really anywhere else in the hospital that you have to do that kind of stuff. So, and then you might say, well, okay, you have to be in here for 9 hours. That's a really long time. What about a bathroom? What do you do with that? And so this chamber on the other side of this door, we can set up like a washroom, so we can put a chair in there with a bedpan for ladies, or depending on what you have to do, and or a bottle for guys. And then so people, or staff or patients will go in there, do their business, and come back in here. Yeah, so it's possible. Most of the staff now have trained themselves that they don't have to use the washroom when they're in here, depending on how much coffee they consume before coming. And then our patients that are in here for a long time, we usually use the washroom. Our elective patients are only here for 2.25 hours. We don't usually have to use the washroom. Yeah. And the part that you see over here, the little kind of chamber over there that has a door, that's called our medical lock. Medication, we can transfer medication, chart materials, food through there, because you can imagine being here for 9 hours, you might want some food. And so the size of that chamber was decided on based on a pizza box. As long as you could fit a pizza box, that was okay. So that's why it's the size it is. It had to be able to fit a pizza box. And so it allows us, even while we're under pressure, to have access to medications. Because you can imagine some of our patients need a lot of medications, and not so much. And then you might think, well, our patient's stuck in here once we start our treatment. And so no patient is ever stuck in the chamber. So if our elective patients, if somebody's feeling ill or sick or just doesn't want to be here anymore because they're too anxious, and Ativan's not working for them, or they don't want to try Ativan, then we can take anybody out at any time. So that's also what this other lock is used for. And so when this is pressurized, this chamber is pressurized, and that one usually sits at surface, unpressurized, so that we have the ability to send in a staff member at any time to come in and either assist the nurse that's in here with what's going on. So if we have cardiac arrest, we can send people in and help to deal with that. We have a protocol on how to get the patient out quickly and still keep our staff members safe, because as I mentioned earlier, we're just like scuba divers. And so if somebody's having a cardiac arrest, we can't just surface the chamber, because the tender that's been in here may have been in here for up to 6 hours, for example. And if they just surface the chamber, we would most likely have to push those. And we might have it bad enough that we would be quite seriously. And so we have protocols designed so how to swap out tenders so that the tender that's in here doesn't get exposed to pressure that it's supposed to get exposed to, while still getting the patient out as quickly as we can so the protein can access to it. Unfortunately, we only had one group in the chamber. That's really very unfortunate. So we just want to just No. The big red button is part of our fire suppression system. So there's 2 in each chamber. There's one there and one behind that door over there. And you'll see on the ceiling there's some spiky kind of things. those are our sprinkler heads. So if that button gets pushed, water will come from a pressurized tank and come into the chamber at 250 liters per minute to try and extinguish anything that's burning. And so that's one part of our fire suppression system. We do have another one, which is the red hose. There's one here, and again, there's one in the corner, which has an auto, so you can spot fight a fire, but I would just push the button if I thought there was a fire. And we actually bring staff in here, try to do it once a year, and give them the experience of pushing the button while they're in here, and it's pressurized, so we can see what it's like to be in this environment with all that water coming in if there's a fire. And we just started doing that a couple of years ago, and what we found was that it was amazing how loud that much water coming in was, because when it was coming we couldn't hear anything other than the water, and how much it decreases your vision. We couldn't see anything either when it happened. So it was a very good experience for us as staff to see that and hear that, so that we know that if it happens, if we have to actually use it, that we have a little bit better prepared to deal with what's going to happen next, and can kind of help our patients understand what's happening. Yeah.
How much of the gear in here will fail if you have to do that?
Well, all of our stuff, so electronically, so any electronics that come in here have gone through a very rigorous process with the biomeds. So after you have a fire, these probably wouldn't work anymore. They're designed that you wouldn't have, you're not at risk of electrocution, for example, but because anything that's coming in here is low voltage. So coming in these monitors, it's like, I think 16 volts. The ventilator, same thing, 16 volts. So it's not like we have wall plugs like we do outside. And that's, when I was talking about equipment, so that's part of what we have to look at for equipment. So any piece of equipment that we bring in here has to be able to function on low voltage. And so, for example, pumps, IV pumps. Anybody that's happened to be around IV pumps when they're not plugged in has certainly heard the alarms going off saying low battery, and it happens like 5 minutes after you unplug it.
And your patient goes to sleep?
Yeah, and so we can't use those on battery, for example, or we would never make it, because some of our treatments are 9 hours. And we have the same kind of pumps as the rest of the hospital has, the Alarics. And so luckily we have a very good relationship with the biomeds, who are quite integral to our program. And they came up with a way of, so this is our plug-in, akin to a wall plug-in for you guys outside, but it's only delivering 16 volts of power, so same as a battery. But the pump thinks it's plugged into the wall. So it'll function just like it would if you had it plugged into the wall. It doesn't alarm, and we have unlimited power, which is wonderful for us. And those pumps also have had to be taken apart and cleaned. So any lubricants have to be cleaned out of products that come in the chamber and replaced with oxygen-safe lubricants. So if somebody comes down with pumps from the ICU, we have to switch all of their lines from their pumps to our pumps because their pumps can't come in the chamber. So we have to make sure that we have enough pumps for them. And sometimes patients come with, like the most we had was 12 IV lines coming in here. So a CSICU patient coming from OR potentially can have 12 lines. So not only does it take a long time to get patients ready to come in the chamber, but we have to make sure we have enough pumps. And so sometimes we'll actually have to negotiate with the ICU and say, okay, well, what don't they need, absolutely need? And so stuff like insulin, so if they have an insulin drip running, we'll usually take those off. If they have extra flushes, we'll take those off, just so that we can have the least amount of equipment in here as and the same with this ventilator. Like I mentioned, this ventilator is the only one that we know of that's been specifically designed. It's Italian, it looks nice and sleek. It's the only one that's been designed specifically to function in this environment. And so if you can't just take a ventilator that they would normally use in ICU, because it has so many bells and whistles and electronics, and it just wouldn't function in you, and it would be a high risk for fire. And even a lot of the transport ventilators you might think would be a good option. Well, unfortunately, they produce a lot of heat. So if anybody's ever been around one of the turbine kind of transport ventilators, they produce a lot of heat. And there are certain regulations that we have that we can't have things that are above a certain temperature in the chamber. And so fortunately, there is a company that produced this one. And it allows us to treat patients under pressure. It functions just as you would normally expect it to at surface. And does all the accommodation for pressure change. So as I mentioned, as you go deeper, density of gases change. And so that affects the flow dynamics. And so when you're giving somebody a certain amount of ventilation at the surface, if you pressurize them, you can't give them that same amount of ventilation and assume that they're going to get the same results. You have to actually increase by a factor to pressurize. And so we had an old ventilator, unfortunately you don't get to see it, but it was really old, from like the 70s, I think. And it was a bigger box, and it was a bellows, called a bellows-driven ventilator. And so that meant it actually had bellows that worked, and scissor valves that would open and close inside. But we had to adjust it constantly as we changed pressure to try and accommodate that pressure change and deliver the amount of gas that we wanted to deliver to the patient. And unfortunately, it was adequate to ventilate a patient in the chamber, but it wasn't great. And so what we tended to see was somebody would get what's called hypercapnia. So the CO2 would go high. So it would go up in the 50s, 60s, which isn't great for a couple of reasons. It's not good for the patient. It also increases the risk of CNS oxygen toxicity. Because when you have hypercapnia, the blood vessels in your brain dilate, and so you actually get more oxygen going to the brain, which is a good thing, but for oxygen toxicity, it's not a good thing. And so it was one of our big challenges. And if you had a difficult patient to ventilate, it wasn't great at doing that either. And so we just got this one not that long ago. We've only used it 5 times, I think, on patients. And so far, I'm quite happy with it. We haven't treated enough patients to know if it's going to make a difference, that big of a difference with the CO2 retention. Because we're not quite sure if it's actually the ventilator, I think it's the ventilator, or whether that's the environment. So when you're pushing gas through a fixed orifice, being the trach, it may just be an environment thing, but you can't push any more gas and pressure that's that dense through that opening. And so hopefully as we treat more patients, we'll find that it does actually make a difference.
Do you only treat intubated patients here that has a trach, or will you take ET tubes in
Yeah,
here?
ET tubes, yeah.
So ET tubes.
That door just seal with the pressure, doesn't have a mechanical latch as well.
So all of our doors seal with pressure. So even though this one has a latch, that latch is really just there to keep it closed, so it's not swinging open. We have no latches per se to close the door. So it just, once it's closed, it takes very little pressure to keep it closed, like 0.3 of a foot before it's closed. And then once it's closed, you are not going to open that sucker because PSI pounds per square inch. You get 30 pounds per square inch, which is what we pressurize to, it's about 30 pounds per square inch. That door has a lot of pressure on it.
Yep.
So, and then we have cameras, so you see there's a couple of cameras on the outside that you can see through the portals. So the operators have closed circuits, so they can see everything that's happening inside. We also have wireless communications through our bell packs and go to the drive-through to the car owners, and so that we can have good communication. When we're pressurizing to 165 feet of seawater, we're going quite quickly, and it produces a lot of noise in the chamber. So if we don't have that, you can't really hear, you can't talk to anybody outside. So, and sometimes we have to tell them certain things when we're pressurizing. For example, if we have a patient who's conscious, one of the big things that they have to be able to do in the chamber is make sure their ears are clearing and their sinuses are clearing. Very similar to if you're on airplanes, on the mountain, for the scuba divers, when scuba diving. And so for our elective treatments, we pressurize at a fairly slow rate, which is 4.5 feet per minute, which is slow compared to diving. So for example, in diving, you might go to 60 feet, whereas when we're pressurizing for our elective patients, we go just at 4.5 feet per minute. And the reason we go so slow is we have quite a broad spectrum of patients that we treat, from from young to quite old. And for whatever reason, if somebody that's in their elder years hasn't had to worry about clearing their ears previously, they have a really hard time getting that technique to clear their ears. There's something called the Valsalva, modified Valsalva, which most people with certain scuba divers learn. That's where you plug your nose and you blow out your nose with your mouth closed, and it pushes air into your middle ear. It allows you to adjust to pressure. So it's a really hard technique for some people to grasp. The other thing is some people just anatomically, they can't clear their ears. So because you're relying on a eustachian tube that connects your throat to your middle ear. And there's a little flap there that when you do that, it opens that flap and it allows air to go into your middle ear. Some people they're just the way they're built anatomically, they can't do it. Or they have what's called eustachian tube dysfunction. So if they've had, for example, they have radiation in that area, it can affect the eustachian tubes, they can't clear their ears. So that's one of the reasons why we're here as nurses, to make sure that they're clearing their ears and they're able to do it okay. And do education. We'll give them something called Ultramin. I don't know if anybody's had Ultramin, but it's a fast-acting decongestant. So if they happen to have any swelling right around that flap, we'll give them some Ultramin and it'll run down the back of the throat, ideally hit that area and clear their ears. If they can't clear their ears, we'll have to take them out of the chamber and they go see ENT to get some tubes placed. It's just very similar to what, or exactly the same as what kids will get placed for if they have recurrent ear infections. And it's just a tube that sits in the eardrum, or tympanic membrane. It allows air to go easily flow in and out of the middle ear. So about I think the percentage we've noticed is 10 to 20% of our patients can't clear their ears. So they'll have to go and get that done. For our ICU patients who are unconscious and sedated, they get rhingotomies done. So the physicians here will just put a little cut in their tympanic membrane to allow air to go in freely between the middle ear and the other side. Otherwise, their eardrum will because they won't have the ability to actively clear their ears, so potentially their eardrum will rupture and cause other problems besides just rupture. If you create enough negative pressure in your middle ear, you can burst what's called your round or oval window. So in your middle ear, there's a membrane called the round window, or I'm not sure which it is. And on the other side of it is the inner ear, which contains the lymphatic fluid, which is in the cockpit. And so if that ruptures and that fluid drains out, then you get vertigo, you have hearing problems, and so somebody's got lots of issues, getting more issues. So they'll get their eardrums. And certainly when we're going to 165 feet CUR, because we'll travel more closer to 50 feet per minute for that one. So for some people it's quite fast, so we just have to make sure. Any questions?
Have you done peds in here before?
We do. We cover all age groups. We've even treated a very young little child, which scared the crap out of us, but we've done it because we're not peds nurses by any means. And so anybody that comes, we treat. Carbon monoxide poisoning for emergencies is kind of the most common thing we'll see for kids. So, if a family in a house and the furnace is malfunctioning, we might have to treat the whole family. So usually we try and use the same equipment, so the hood system. So if they're small enough, they may just lie in the hood and you tie up the end. Or if they're a little bit older, we'll have the hood that comes around and it'll just come around their waist. And so the whole upper body will be in the hood. So it's a bit of a challenge sometimes depending on the child. Some of them like being in the hood. So we have some kids movies that we put on and we try and entertain. Kids that are younger than about 10 will generally always go to Children's Hospital to have neurogotomies done before coming here for treatment. Kids, a lot of kids have a really hard time clearing their ears. And so what we found was if they came here and we tried them, and they couldn't clear their ears. It was
Emergency department, control
it's,
access, level.
it was a very lengthy process then to try and send them to children's, wait for them to have tubes placed and then come back. In the meantime, our whole team is waiting here for them to get that done. So we now have a process where if somebody's coming in that's a kid for carbon monoxide poisoning, we try and divert them to children's, so they'll go there, get their tubes done, and then they'll come here, so, or not tubes, just cuts, so that they can come here and have treatment. Yeah. If you want, we can exit out here and I'll show you the rest.